obtain MRD. Before that, we have our special guest, the chief guest, Dr. Girish Balekai from Dharwad. Dr. Girish Balekai is MD, General Medicine, MRCP UK, MRC Path Hematology, CCT UK. Is professor and head Department of Clinical Hematology at STM Medical College Hospital, Dharwad, Karnataka. He did his MD in medicine from Bangalore Medical College. After this, he went to UK to pursue further studies. After doing MRCP UK, he joined clinical hematology training in Southwest England rotation. He completed 5 years of training and obtained FRC Path Clinical Hematology. He worked as consultant hematologist in Southern University Hospital, Essex, UK for 4 years. He was led in South Essex lead in teenage and young adult cancer patients. He started first clinical hematology setup in the north of Karnataka. Now he has developed now that center has developed to be a broader unit catering for the pediatric and adult treating benign and malignant hematology patients. I request him to inaugurate our webinar today and also give some words of wisdom for the youngsters. I'll stop sharing and request him to take over.
Good morning, sir. Can I audible, sir?
Yes, please.
Yes. Thank you very much, sir, dear Agarwal, sir, and Mumbai Hematology Group for giving me an opportunity to be the chief guest, which is a really honor for me. And I thought I'll just word of wisdom is mainly I'll do my introspect about the career in hematology and why I choose hematology and what's keeping me in hematology and keeping me happy and self-contented in the hematology every day. Yeah. So my fascination of some blood cells started back in early my pathology in the second year of MBBS, where I was really was fantastic. Well, thanks to my pathology teachers about it. And later on, when I was in UK doing the medicine rotation, I was like, one of the hematology consultant encouraged me to do some studies, small studies and audits on the hematology. And I grew interest in hematology and took my career in hematology. Since then, I have one kind of look back and never ever regretted in one single moment. Why hematology and why I choose this subject? And that's something what I fascinated was like to start with like how we diagnose hematological conditions. Basically, the hematological condition diagnosis, I feel like it's more like a mathematical solving a mathematical puzzle. When you choose a right investigation and put together all the investigations history and everything, then you make a diagnosis. Sometimes it's very difficult to diagnose the hematological conditions like any other medical profession. So anyway, and second thing is the relationship with the patients is a lifelong, and which I like it. Some people may not like it, but I like that going through their journeys. Like when I see a child with ALL coming back with after completing treatment, coming back with their achieving something, I feel very proud. That was the proudest moment and the happiest moment in my life. And most of the hematological patients are not driven by the the so-called lifestyle diseases. These are pure diseases. That's what I like it. And second thing is like we have a combination of benign and malignant cases. And so we have a happiness in treating some benign and happiness in treating malignant and some complicated cases as well. And it's this challenging. At the same time, I have kind of like basically the hematology is the fastest moving innovative field in any of the medical fields, because in last 10 years, at least 10, 15 years, we have seen the sea of changes, which kind of help the patients as well as to treat those patients. And obviously, after coming back from UK, we started this hematology small department. Now is grown up thanks to my colleagues which are fantastic nursing staff, which are helping us to maintain the kind of a sanity and development and as well. And again, it's hats off to Dr. Agarwal sir about his continuous dedication for the almost year-long dedication to the hematology trainees and aspirants to encourage them all the time and getting a fantastic speakers and keeping us updated. That's it. Thank you very much, sir. Thank you. And we will start the proceedings, sir.
Thank you so much, Dr. Girish, for sparing your time being with us, for all those kind words and the words of encouragement for our junior colleagues. So, well, I now request Dr. Hans Hasselberg to take over.
Hello, everybody. First of all, I would like to thank Dr. Agarwal and the other members of the organizing committee for inviting me to give a talk entitled "A Paradigm Shift in the Early Diagnosis and Treatment of MPNs Sooner, Better Than Later." I will go into the rationale and perspectives of early intervention with interferon alpha, and also talk about monotherapy or combination therapy to obtain minimal residual disease. These are my disclosures, and just here the schedule. I will start with MPNs as a human inflammation model, vascular diseases, thrombogenic diseases, and then I will also underscore a very important message that MPNs are massively underdiagnosed blood cancers. I will use type 2 diabetes mellitus actually as a human comparator model for chronic inflammation. And I will go through the conventional treatment goals and challenges. I will address MPN as multimorbidity diseases, and I will address future treatment goals that imply minimal residual disease with interferon alpha-2 and also with statins and combination therapies. Then I will close my talk by the challenges in the future, the unmet needs and unsolved issues, and I will finally address CHIP clinics, knowledge hubs for preventive medicine. This is our MPN inflammation model, telling us the story that these diseases, they are driven by chronic inflammation across a vicious circle from the very early ET stage, actually from the CHIP stage, and NJAK2 positives towards polycythemia vera, and then after 20 to 30 years, the advanced myelofibrosis stage, the advanced burnout stage of the disease. Chronic inflammation gives rise, we know it, to premature atherosclerosis. It also gives rise to thrombosis and cancer as well. The MPN patients today, we have to imagine that these patients, they are actually very often multimorbidity patients, implying a close interdisciplinary collaborations between neurologists, cardiologists, hematologists, and others. MPNs as inflammatory diseases. We have described MPNs as a human inflammation model, for cancer development. That chronic inflammation actually is a promoter of mutagenesis in ET, PV, and myelofibrosis, and in this way, it is a biological continuum, human inflammation being a constant driver of clonal expansion and evolution. We have also addressed this in a recent paper in Blood on the pathobiology of thrombosis, microvascular disease, and hemorrhage in MPNs, telling the story again that inflammation is a very important driving force, even as I will address later, from the very early CHIP stage, clonal hematopoiesis of indeterminate potential, towards overt MPNs, other cancers, and also cardiovascular diseases. I told you that one of my key messages today is to tell you that MPNs are massively underdiagnosed cancers. We can tell this story today because we screened 20,000 citizens a few years ago and found that actually 645 harbored the DEC2 mutation and 35 harbored the CALR mutation. And we know today that several of these CHIP DEC2 positives and CALR positive citizens or patients, they have today developed overt MPN. In Denmark, when we extrapolate these figures, we know that in Denmark, at least 10,000 citizens have undiagnosed MPN, not that they only harbor these somatic mutations, but that they actually have undiagnosed MPNs being constantly exposed to an increased thrombotic risk. In US, this is equivalent to 550,000 citizens in US having undiagnosed MPNs. And they are constantly exposed to an increased risk of life-invalidating, life-threatening thrombosis and sudden death. Here I have shown you the CHIP stage. And this is our Næstved cohort that we screened, 20,000 citizens. And as you can see, what we know today is that some of them, they have a constantly low DEC2 allele burden. For instance, a DEC2 allele burden around 0.5 to 1, and they remain there. Others, they increase their DEC2 allele burden steadily over the years, about 1.50% per year. We have shown this by mathematical modeling studies. So this figure shows you what we believe are determined factors for rise in these mutations, for development of these mutations. And one of the major driving forces, we believe, for sure, is chronic inflammation, giving rise to not only MPNs, but also other chronic inflammatory diseases, ischemic heart failure, etc. What is also important to say is that smoking is for sure a very potent systemic inflammation stimulus. And we have in 5 papers shown that smoking actually triggers clonal expansion and evolution in DEC2 positive and CALR positive patients. So we have a continuum with chronic inflammation, premature atherosclerosis, vascular diseases, thrombosis, and cancer. Importantly, the CHIP DEC2, having the DEC2 mutation in the CHIP stage, actually also promotes thrombosis. This has been shown by Volak and Mulali's group, showing that even in the CHIP stage, the DEC2 mutation promotes thrombosis. And I will come back to PAL4, which is required for DEC2-driven neutrophil extracellular trap formation and thrombosis in vivo. So this is a very important message. Let us then look at these figures. In figure 1, you have the CHIP DEC2 landscape with at least 2 ultimate scenarios. A constant low DEC2 allele burden likely being explained by a low frequency or concurrent infections might theoretically fuel clonal expansion. That is the green line. And then the red line, that is clonal expansion giving rise to several complications, which I will also address later. In figure B, you see the impact of chronic inflammation in CHIP citizens transforming into overt MPN. If we do not intervene, we will see similar events as in figure A, with several complications occurring during the years. But if we start treatment with interferon alpha, we lower the very inflammatory and potent DEC2 mutation to a very low level. And Doing this, we also lower the risk of thromboembolic complications. Let me, for a while, make similarities between MPNs and type 2 diabetes mellitus. In type 2, we have the elevated blood sugar levels. In MPNs, we have the elevated cell counts. But try to see what chronic inflammation in both diseases gives rise to. They are very, very equivalent. Accelerated atherosclerosis, cardiovascular diseases, drusen, and development of age-related macular degeneration, the most common cause of visual disturbances and blindness in the Western world, and also chronic nephropathy. MPNs give rise to chronic nephropathy and also an increased risk of second cancers. If we then look at the pathways that are activated, they are actually overlapping very much. Early aging, early immune aging are keywords for both diseases. And keywords for both diseases are also the development of thrombosis, driven by chronic inflammation, giving rise to in vivo white blood cell activation, in vivo platelet activation, in vivo endothelial activation, and circulating leukocyte plate aggregates, premature atherosclerosis, and circulatory disturbances. So I love to call MPNs not only inflammatory diseases, but actually also type 3 diabetes mellitus to underscore the similarities that we have. Type 2 diabetes mellitus, they have a debut of the disease at the diagnosis. They come with the complications after having an unbalanced blood glucose homeostasis for several years. In MPNs, we have had an abnormal cell and bone marrow hemostasis for 10 to 20 years before they are diagnosed. And that is a very important message. Let us then address the risk factors for heart and blood vessel diseases. We all know them, several of them. Elevated blood pressure, I have addressed elevated blood glucose and cholesterol, but actually also the white blood cell count is a thrombogenic factor and platelets as well, also in the background population. We know smoking, and now we can add these somatic mutations. Here I address the JAK2 mutation and also the TET2 mutation. We have, at least cardiologists have known for decades the importance of platelet leukocyte interactions that link inflammatory and thromboembolic events, that elevated leukocytes and elevated platelets are intimately involved in the development of atherothrombosis. And most recently, my colleagues have shown that the neutrophil count and cardiovascular disease, they are not only associated, it is beyond association. High neutrophil counts are causal risk factor for atherosclerotic cardiovascular disease. And that is actually the reason why we see so many MPN patients heavily burdened by cardiovascular diseases. Also, high platelet counts and high hematocrit associate with arterial thrombosis in the general population. This has been shown by the same group, concluding that high platelet counts, they imply a 1.8-fold increase of arterial thrombosis in the brain, and high hematocrit associates with a 1.5-fold risk of arterial thrombosis in the heart. But neither high platelet or high hematocrit was associated with increased risk of venous thromboembolism in this study. And what then about smoking? Yes, I told you that, and it is important that smoking actually is also a driver for MPN clonal evolution. And since the JAK2 mutation induces a chronic inflammatory state equivalent to heavy smoking, this message also implies the importance of lowering this inflammatory and thrombogenic mutation, and the drug that we will come back to is interferon alpha. What are the conventional goals, treatment goals in ET and PV? We know them. It is to minimize risk of thrombosis and bleeding. It is to minimize risk of transformation to myelofibrosis and minimize risk of transformation to AML, the ultimate goal being improvement of quality of life. What are then the current treatments? We have at many MPN centers of excellence around the world, the PV patient today is only treated with phlebotomy and aspirin. But phlebotomy and aspirin do not target the malignant clone. So only treating the PV patients with these modalities will not prohibit clonal expansion and clonal evolution. There is a risk of disease progression without targeting the malignant clone from the early phase over the transitional stage during the following 10 to 20 years. And then we have the advanced post-EV or post-PV myelofibrosis stage, which for most patients imply a very bad prognosis with death within the next 2 to 5 years. The current treatments, just to repeat, in low risk, phlebotomy and aspirin, and as told you, it do not target the malignant clone. In high risk, in most centers today, hydroxyurea is added, but hydroxyurea does not target the malignant clone. It very rapidly normalizes elevated cell counts, and it has also been shown to reduce the risk of thrombosis, but it does not prohibit clonal expansion and disease progression. It does not target the malignant clone. It does not target the inflammatory state or the inflammatory comorbidities. And what are then the MPN multimorbidities? As you can see on this PowerPoint, there are several. So the novel preventive strategies, in my opinion, and we do this in our clinic, is to screen high-risk MPN profile patients, for instance, cardiovascular disease patients, for the inflammatory and thrombogenic JAK2 mutation. As I will show you later, we have just recently published in Blood Advances that newly diagnosed ischemic stroke patients, the JAK2 mutation is highly prevalent, 11.2%. So we have to set up screening studies to find the patients before they develop repeated major thrombosis in the brain, in the heart, in the lungs, and elsewhere. Earlier diagnosis of MPNs and associated comorbidities, earlier treatment of MPNs and associated comorbidities. Just to underscore again that the JAK2 mutation promotes atherosclerosis and gives rise to thrombogenesis and to plaque inflammation together with elevated inflammatory cytokines. Please remember that JAK2 mutation generates reactive oxygen species and thereby inflammation, and JAK2 mutation gives rise to an increased levels of neutrophil extracellular trap formation, netosis formation that is so important for thrombosis development. To repeat, earlier diagnosis of MPN and MPN-associated comorbidities in high-risk MPN profile patients, and an improved understanding of the pathogenic mechanisms for CHIP to MPN development, I believe is very important issues for the future. Therefore, we perform molecular screening for the JAK2 mutation in high-risk patient cohort. I have told you about cardiovascular disease patients, and we perform molecular immune cell, cytokine, and microbiome studies in these patients as well. We have started with cardiovascular disease patients. Now we go further to patients with chronic obstructive pulmonary disease and patients with all these diseases. And as you can recognize, several of these patients, they have elevated leukocyte counts and they have elevated platelet counts, which we have learned in the school that they are reactive. But please take the home message that you should always consider the MPNs in patients with elevated cell counts. Then you will find them. I told you previously that we have screened 550 patients with ischemic stroke and have found that JAK2 mutation is prevalent in 11.3%. A very high percentage. And several of these patients, they are now in my outpatient clinic with diagnosed MPN and have normal cell counts during treatment with interferon alpha. Patients with ischemic stroke are 2.5 times more likely to harbor the JAK2 mutation compared with matched controls. And actually, even this study, together with others, they support the JAK2 mutation as a novel risk factor for ischemic stroke in the future. Also, elevated white blood cell counts in patients with ischemic stroke gives rise to an increased mortality and new vascular events. And we have not in that study screened for JAK2 mutation, but just to tell you that even having an elevated white blood cell count after you have had the first ischemic stroke increases the risk of a second stroke. So elevated white blood cell counts in ischemic stroke patients, they are associated with increased mortality and new vascular events. And this finding indeed underscores the urgent need for screening for this protein inflammation-mediating mutation, a new risk factor for stroke in all newly diagnosed stroke patients. And we believe that this strategy will reduce the increased risk of new strokes by much earlier diagnosis and treatment of MPNs. Also take notice that the JAK2 mutation actually may also be involved in abdominal aortic aneurysm development. And this has been shown nicely in a recent paper in Hematologica. And we have taken this into a study where we have screened 7,500 individuals from the Danish Dancavas trial. We know that 500 citizens have abdominal aortic aneurysms in this cohort. And now we are analyzing where the cluster of the 7.2% of the 7,500 citizens where the JAK2 mutation actually clusters. Is it so that it actually clusters in patients with cardiovascular disease? We believe so. And are they in particularly clustering in patients with aneurysms? We have also shown that the JAK2 mutation associated with an increased risk of artery and aortic valve calcifications in patients with MPNs. So if patients, in particular patients with a JAK2 allele burden above 50, we know that these patients have an increased risk of valve calcifications. Patients with MPNs have a very, very strong tendency to develop drusen. And as you can see on the red line, drusen development is even much more earlier than in very large other drusen studies, for instance, in type 2 diabetes mellitus, the Rotterdam study and other studies. So to have MPN is closely linked to drusen and also closely linked to age-related macular degeneration. That is very important. And actually, again, reinforcing the message that chronic inflammation is a driver of MPNs, since chronic inflammation is considered a very important driver for drusen development as well. What about osteoporosis development? A very common disease in the general population. Chronic inflammation, my Danish colleagues have shown that MPNs are exposed to an increased risk of osteoporotic fractures. And now we have advanced the hypothesis that it may be due to osteoporosis development. Several other studies have written about this, and we are confident that there is an association between the DAC2 mutation, chronic inflammation, and osteoporosis development, and we will hopefully be able to prove this in the next year or two. I told you in my initial part of my talk that MPNs are associated with chronic nephropathy, very similar to the development of nephropathy in type 2 diabetes mellitus. And we published this years ago, and it has now been repeatedly confirmed by others. So actually, you can tell the story that ET over PV or not over PV develop chronic nephropathy, very similar to patients with type 2 diabetes mellitus. What is relatively new is that there's also an association between CHIP and JAK2 positivity and chronic liver disease. That CHIP, the clonal hematopoiesis, is associated with an elevated risk of liver inflammation and chronic liver disease progression through an aberrant inflammatory response. And importantly, JAK2 mutated CHIP implies a 16-fold increased risk of chronic liver disease, and therefore, of course, we have to focus upon studying liver function in patients with MPNs, and if they have elevated liver enzymes, it may be due to chronic inflammation as well. We all also know that MPNs and inflammatory bowel disease are closely related. The Silver Group showed it years ago, and we have shown it in a large Danish study that the risk of inflammatory bowel disease is increased in patients with MPNs. Actually, it may also arise from the gut. As you know, increasing interest has been on studying the microbiome in MPN patients, and we have this interest in our study in research group as well. Importantly, MPNs also are associated with an increased risk of cancer, and this increased risk of another cancer, of course, a transformation of MPNs to acute myeloid leukemia, but it is non-hematological cancers. They have an increased risk both after the MPN diagnosis and before the MPN diagnosis. Probably due to defective tumor immune surveillance, we do not know it, but this may actually be the reason why they have this increased risk of second cancer. So when we have a patient with arterial thrombosis in MPNs or a venous thrombosis, we should always consider that it may not only be due to the MPN disease per se, but it may also be elicited by a second cancer, which we know are additional thrombogenic factor in a subset of MPN patients. But what is the role of the elevated platelet count for the observation that when patients with MPN are hit by a second cancer, this second cancer implies a decreased survival? It may be that the platelets actually shield tumor cells from being attacked by NK cells during their journey from the local site during metastasis. So by activating platelets, cancer cells may not only provide a pro-coagulant surface that facilitates cancer-related coagulation, but it may also induce adhesion of platelets to cancer cells, and thereby providing a shield for tumor cells, protecting them from attack from surrounding immune cells, including NK cells. And we have another mechanism might be that the CD8 T cells, they actually aggregate with platelets. When I tell you all this, it is because I will come back to the rationales and perspectives for early treatment, because even this message tell us that we have to normalize elevated platelet counts in patients. The clinical consequences of not doing so is that the patients may have defective tumor immune surveillance, and they may have an increased risk of recurrent infections, which has also been shown in MPN patients. So we have to rethink novel treatment goals to prevent thrombosis. We have to rethink that we should normalize the elevated red cell count, also the elevated leukocyte count and the elevated platelet counts. The future goals being minimal residual disease, operational cure, and improvement of quality of life. And the targets should be the malignant clone, the concurrent inflammatory state, and the inflammation-mediated comorbidities. We should target the malignant clone and ensure normal cell counts, and in women, that is a normal hematocrit in PV patients, 0.42, and in men, 0.45. A normal leukocyte count and normal platelet counts, and also meaning that we should normalize elevated inflammation markers, including C-reactive protein. And what have we to do with? We have interferon alpha, and I will also talk about statins and combination therapies. Why early intervention? Because we have a stem cell targeted therapy named interferon alpha-2 that depletes the bone marrow from the clonal stem cells. And we have a huge clinical experience, 30 years, with several single-arm studies in about 1,000 patients, showing that interferon alpha is both safe and efficacious. But also remember that interferon is a draft horse. It is hard work, and it is the long, tough pull, meaning that we, after 5 years, will see that the DEC2 allele burden significantly lowers more than, for instance, hydroxyurea treatment, and I will come back to this. It is also important that we know that only one agent is able to induce minimal residual disease after approximately 5 years of monotherapy, and that is interferon alpha. And here is the first patient published showing that after about 5 years, this patient develops low burden DEC2 with a normal bone marrow. And still the patient has normal bone marrow, and it receives intermittent interferon alpha-2 treatment, not maintenance treatment, but intermittent treatment. And I think that this intermittent treatment with pauses and discontinuation may be more effective than that maintenance treatment with interferon. My colleagues at Weill College has also shown that long-term treatment of polycythemia vera with interferon alpha is associated with an increased myelofibrosis-free survival, and a normal life expectancy is possible. And when should we then treat with interferon? We should not watch and wait. We should start at the time of diagnosis. All cancer biology tells us that if we do not start at the time of diagnosis of a cancer, then it will develop, the clone will expand, subclones will develop, resistance to treatment will develop, and the patient will have metastasis at last. So we have to treat at the very early time of diagnosis, where the tumor burden is at the minimum and is most efficacious. And we have actually shown this in mathematical modeling studies. To the left, we have the DEC2 allele burdens kinetics during the years, and we have shown that actually early intervention with interferon alpha is also highly cost effective, shown on the figure to the right. This is just a repetition of a figure that I have shown you previously, but please remember that early treatment with interferon alpha is likely also cost effective, because we can then later discontinue interferon for periods of 1, 2, even 3 years with normal cell counts, and then we can reinstall interferon alpha, and then it might be even more efficacious. That has to be shown, and we will do such studies in our outpatient clinic during the next years. Quelling the fire in the early disease stage, quelling chronic inflammation, prohibit clonal evolution and thrombosis, that are my key messages. We should stop the fuel supply by interferon alpha, and we should consider in those patients not responding adequately to interferon, of course, always to do next generation sequencing to disclose if there are so-called interferon resistant clones, such as the TET2 mutation might be, and then we could add a JAK1/2 inhibitor or statins. And I will show you this in the following. Just to repeat, interferon alpha-2 may prohibit atherosclerosis development by prohibiting JAK2 mutation. And how can I say this? I will show you later. First of all, we know that the PAL4 is significantly upregulated in MPNs, and during interferon treatment, this thrombosis promoting protein is normal regulated during treatment with interferon alpha-2. Pral's group has shown that several thromboinflammatory pathways are upregulated in ET and PV patients, and we have shown that these upregulated thromboinflammatory pathways, some of them are normal regulated or significantly downregulated during treatment with interferon alpha. All this calls for earlier treatment, sooner, better than later, to normal regulate thromboinflammatory genes. Very importantly, interferon alpha-2 also favorably impacts deregulated atherosclerosis genes in PV and related neoplasms. We have shown this most recently, and a paper will soon be submitted. We have also shown that several immune genes are deregulated, and these deregulated genes, including downregulating of HLA genes, they are actually upregulated or normal regulated during treatment with interferon alpha. Here you have a figure showing defective tumor immune surveillance in MPNs, and you have the downregulated HLA genes so that the immune system cannot kill the tumor cells. But when you then add interferon, you have enhancement of tumor immune surveillance and upregulation of HLA genes so that T cells and K cells can attack and kill the malignant MPN clone. I have already addressed the importance of decreasing platelet counts and thereby decreasing CD8 T cell platelet aggregates and decreasing and thereby prohibiting T cell suppression, as we have shown in a recent paper. It is also important to tell you that interferon alpha actually tends to normalize an abnormal microbiome in MPN patients. And we believe that this is may actually be a very, very important mechanisms of interferon. We all know that gut microbiome actually is a modulator of chronic inflammation. And if interferon actually normalize the microbiome in MPNs, this may be one of the mechanisms by which interferon restores normal cell counts, etc. Deregulation of oxidative stress genes is marked in patients with MPNs. And what are the clinical implications of this? This is a simplistic model of hematopoietic stem cell niches. This is an even more simplistic stem cell niche. The chicks are flying prematurely. They are escaping the burning nest, the stem cell niche, due to oxidative stress, ROS accumulation, genomic instability, mutagenesis, and metastasis. And here you have them, the immature birds in the circulation, mobilization, metastasis, and myeloid metaplasia. Actually, interferon alpha favorably impacts deregulation of oxidative stress genes, meaning that interferon alpha may keep the young birds in their stem cell niches, may increase the adherence to the stroma more effectively. And this is actually not new information because this has been shown several years ago, decades ago in CML patients. This also calls for initial treatment with interferon to normal regulate these abnormally regulated oxidative stress genes sooner, better than later. Then again, why interferon? We know not only that several single-arm studies have been performed during the years, but now we can also look at randomized interferon alpha-2 trials. And here we have the following: the phase 3 randomized PROUD and continuation study, the MPD consortium trial, the Danish DALIA trial, and the ROPIC low-risk PV trial by Barbuet co-workers. I will just shortly address the Danish DALIA trial. And this trial, we have shown that treatment with interferon alpha was associated with distant molecular lead responses in patients with JAK2-mutated MPNs compared to CALR-mutated MPNs. And among patients treated with interferon alpha who didn't achieve complete hematological remission, DNMT3A mutations emerge more frequently than non-DNMT3A mutations. But this DALIA trial, a multi-center trial in Denmark, including approximately 200 patients, have now been finalized, and the clinical paper is soon to be submitted. And here we show the results that the proportion of patients over time having a complete hematologic remission is steadily increasing, but actually also on treatment with hydroxyurea. But the major difference is that the molecular responses on pegylated interferon alpha is much more pronounced after 36 months and afterwards than during treatment with hydroxyurea. And this is a very important key message of this study. And also the JAK2 kinetics you can see the response status at 60 months. It's better with interferon alpha-2. And the maintenance response are also better on interferon alpha. Treatment discontinuation occurred in a large proportion of patients, unfortunately 40 to 50% during long-term treatment for several reasons, including toxicity and others. So this is also important to adhere to. So this study showed that pegylated interferon alpha discontinue rate was high despite a low approach. Try to imagine that we used Pegasus 45 microgram once weekly only, but also that patients with good pegylated tolerability had superior efficacy response as compared to hydroxyurea beyond 36 months. And that is also an important message. Others have shown this with Ropic interferon. The event-free survival in patients with PV treated with Ropic versus best available therapy, that Ropic is better than best available therapy, most recently published in Leukemia. And this also holds true, as shown here. You can see the blue bars indicate a complete hematological response at the latest available assessment, and the yellow bars indicate no response at the latest assessment, telling the story that Ropic interferon alpha-2b is better than best available therapy. Long-term outcomes of PV patients treated with Ropic interferon. You can see on the right side the figure that is very, very similar to our figure in the DALIA trial, showing that the JAK2 allele burden steadily decreases over time, but it does not so in the control arm. Important to tell is that the treatment-related adverse events leading to discontinuation, when you compare Ropic interferon with controls, there are more patients, about 10% in the interferon group than in the control group. But disease progression to myelofibrosis and leukemic transformation was more rare in the Ropic arm, although the figures, I admit, are small. Ropic interferon and drug survival. This is a most recent paper in Annals of Hematology by Babu's group, showing that actually drug survival, meaning the time from drug initiation to discontinuation of any reason, whether due to safety concerns or effectiveness, that it is actually 58% at 5 years. But please take notice that drug discontinuation due to adverse events is only 14%, and all the other may be due to a fixed low dose of only 100 microgram every 2 weeks, compared to the PROUD study, where they use a dosage that is about 400 to 450 microgram every 4 weeks. Babu and co-workers have also confirmed this most recently in New England Journal of Medicine, that Ropic interferon is for sure more effective in PV patients than conventional treatment with phlebotomy and aspirin. What about statins then? I have told you about the possibility of using a statin in MPNs, and there are several good reasons to do this. First of all, statins are not only cholesterol lowering, they are potently anti-inflammatory, and they have also several anti-cancer effects. And adding to this, they inhibit leukocyte and platelet activation, and thereby having antithrombotic potentials as well. Importantly, statins inhibit JAK2-dependent cell growth, and statins may thereby enhance JAK1/2 inhibition. We have shown recently, because we didn't succeed in setting up a randomized statin study for the simple reason that too many elderly patients receive a statin from the cardiologist. Instead, we did a national register study. And in this study, published recently in Blood Advances, we have shown that statins, even in this CHIP stage and in MPN, protect against development of MPNs. So the message is that statins protect against development of MPN. Colleagues have shown that statin use actually reduces cancer-related mortality about 15%, and this adds further to using a statin in MPN patients who are associated with an increased risk of second cancers. Statin therapy also improves response to interferon alpha, at least in hepatitis patients, and we soon submit a paper showing that the same is true in MPN patients. And others have also published in leukemia research recently that PV patients being treated with a statin, they have a reduced risk of phlebotomies than those not being treated with a statin. What about combination therapy with statins and bisphosphonates? I showed you that patients with MPNs, they have an increased risk of fractures, and we believe that this is due to inflammation-induced osteoporosis. Here is a patient that is treated with both a statin and bisphosphonates and nothing else. And as you can see, the JAK2 allele burden decreases, and so do the elevated cell counts over the years. So this is just a case report, but we really look into this in our future research, how this combination, a statin and a bisphosphonate, might actually influence MPN development. I have again given you all the reasons for this, that statins for thrombosis prevention and phlebotomy reduction, bisphosphonates for osteopenia. It all is so meaningful. Use of statins, survival and incidence of thrombosis among older adults with PV has also been shown by others in a population-based study, that the risk of thrombosis was significantly lower in statin users than in non-users. So to put it together, cardiovascular disease burden should be reduced, and it is increased several years before diagnosis. Statin treatment may decrease the cardiovascular disease burden, decrease thrombosis risk, decrease the need of phlebotomies, perhaps increase overall survival, and it protects against development of MPNs, and it may also be protective against development of other cancers to be shown in future trials. What about then combination therapy with ruxolitinib? We know that ruxolitinib actually decreases elevated inflammatory cytokines in MPNs and also decreases the JAK2 allele burden, likely due to disruption of JAK2-induced inflammation in MPNs. So what about this triplet, interferon alpha, ruxolitinib, the fireman, and a statin? To disrupt the vicious circle very early by intervention with interferon alpha and a statin, and in a subset of patients, JAK1/2 inhibition as well. I believe that this may be the future to prohibit the chicks to fly prematurely from the burning nest, and to prohibit development of myelofibrosis with huge spleen, etc. And ultimately, hopefully also development of AML. Combination therapy with interferon and JAK2 inhibitor is feasible, this is the first case report in my lovely patient, Pia, showing a very rapid decline in JAK2 allele burden over 10 to 12 months. And now Pia has a JAK2 allele burden below 1 on low dose interferon, 45 microgram every 2 weeks, and Jakavi 5 milligram twice daily. And she is healthy and doing very well. This case report with Pia gave the impetus to combination therapy in many more patients, in 50 patients being intolerant or refractory to interferon alpha, published in Cancer Medicine and Hematologica a few years ago. And here you see the very rapid decline after combining interferon with ruxolitinib. You remove the fire, the driving force for clonal expansion, and then you have a decrease in JAK2 allele burden. I would like to address that actually hydroxyurea in combination with interferon may be a very, very good combination. And we will set up studies on this in Denmark, and I really will inspire you to do the same at MPN centers in India. Try to imagine you have interferon, the draft horse, normalizing elevated cell counts within weeks, and you have the very fast horse, the quick work, the fast run with hydroxyurea, which momentarily within hours to days actually normalizes elevated cell counts. But also when it is discontinued, the cell counts rapidly increases, reflecting that hydroxyurea does not target the stem cell, but this work is done by interferon alpha. So this combination may be highly efficacious. It may be more effective in preventing thrombosis, in particular within the first 3 months from diagnosis, where we know for sure that our Swedish colleagues have shown that in that time window, within the first 3 to 6 months, MPN patients have an increased risk of thrombosis, even though we have started treatment. So, and actually it might also impose that it is better tolerated than monotherapy. Please note that hydroxyurea actually also lowers elevated levels of inflammatory cytokines. This has been shown in sickle cell crisis patients, that hydroxyurea potently lowers inflammatory cytokines. What are the challenges for the future, the unmet needs and the unsolved issues? I have addressed that MPNs are massively underdiagnosed. I have also addressed that the clinical consequences with life-invalidating blood clots in several organs without treatment, a significant risk of other cancers, and all these complications and associated diseases are prevalent 5 to 10 to 20 years before MPN diagnosis. This also imposes a huge health economic burden of undiagnosed cancer patients with a high risk of blood clots in the brain, heart, lungs, and elsewhere. And also the comorbidities with organ failure due to multiple blood clots is also a huge health economic burden. And the increased risk of other cancers is also in this context very important. Therefore, the perspectives are early detection and treatment, earlier diagnosis by molecular screening of high-risk MPN populations, earlier treatment with stem cell targeted therapy, earlier diagnosis and treatment of comorbidities, including second cancers, a decreased risk of blood clots, improved quality of life, and improved survival. So the future research directions are several. To explore the determined factors for clonal expansion and an evolution in the chip stage towards MPN's development, multi-omics in the chip stage, better understanding of the role of inflammation in the pathobiology of thrombosis in the chip stage, and also to study the earliest bone marrow biopsy changes in the chip stage by novel technology, artificial intelligence with machine learning, to study associations between architecture and dynamics of extracellular matrix peptides during clonal expansion and evolution, and also very, very important, I believe, to screen high-risk MPN profile patients for these somatic mutations. And then even to set up pilot studies of stem cell targeted therapy with pegylated interferon alpha, statins, and also colchicine in the chip stage. That may be the future by which we can disrupt the vicious circle, as I have shown you previously, can disrupt that early stage develops into advanced stage disease, the untreated disseminated hematological cancer, the myelofibrosis with myeloid metaplasia. When I told you about extracellular matrix peptides, it's simply because years ago in 1990s, this research field was very hot. And now we have revisited this and have set up studies on circulating extracellular matrix fragments as disease markers in myelofibrosis and related neoplasms. And we measure, for instance, type 3 collagen fragments with specific neoepitopes and with this neoepitope technology. What about breaking the clonal hematopoiesis expansion inflammation cycle? As I told you, this has also been reported and underscored in a recent editorial in Blood, where they also mentioned that future trials with monoclonal antibodies that block the inflammation may also be a favorable intervention to prohibit expansion of clonal hematopoiesis. And I add to this very inexpensive drugs such as statins and colchicine. This is a case report, and actually it signatures what I have told you. It is a case report by Miklos Egert from Hungary, who treated a CHIP JAK2 positive patients with a heavy cardiovascular disease burden with angina refractory to conventional treatment. And when the patient received RUPEG, the angina disappeared. And when it was discontinued, the angina reappeared and disappeared when it was reinstituted. So only a case report, but now we have published 5 patients, MPN patients, in whom angina disappeared after treatment with interferon alpha. Statins in the CHIP stage and in MPN, statins protect against development of MPN. I've shown you this, and this is also a future research project. Now I have told you what to do in the very early stage, but I would also like to adhere to a very interesting combination therapy for the future. In those patients who we otherwise cannot treat if they are not candidates for a transplant, namely the MPN patient in the accelerate phase and blast phase. Here, it would be very interesting to study the triple combination of interferon alpha together with DNA hypomethylator and ruxolitinib for reasons that we have addressed in a commentary to a lovely paper by Canadian colleagues. And we believe that this combination may be a future, should be studied in future trials, because in the advanced phase of MPNs, the leukemia stem cell signature is increased, but when it is increased, the interferon signature is lowered. And the interferon signature may be lowered due to a very potent chronic inflammatory state, which then is removed by adding ruxolitinib. So this may be a combination for the future. What about discontinuation of interferon alpha treatment? Is it feasible? We have shown it. I've shown this figure previously, but just to repeat that it is possible. And others have shown it, Kiladian and co-workers, the French group, that it is possible to discontinue interferon treatment. And it may be a safe strategy in MPN patients who have achieved complete hematological remission, but not before the VAF is lower than 10%. I think that it should be even lower, below 5%. Otherwise, they will very rapidly, or not very rapidly, but within months, increase in cell counts again. But if you treat lower, below 5%, you may be able to have them off therapy for 1 or 2 years. We know that CML is the sunshine story in the MPNs. We believe that we also have a sunshine story in the future if we adhere to early intervention with interferon alpha. That is our research in the Danish MPN consortium, where we have introduced a profound change in clinical practice by molecular screening of target populations. And we believe that this is the goal, this is the way to open the horizon for minimal residual disease, operational cure, a reduction in thromboembolic disease, a reduction in cardiovascular disease, a reduction in inflammation-mediated comorbidities, improved quality of life, and improved survival. How should we do this? We cannot just screen a lot of patients. We have to take care of them by an interdisciplinary collaboration, and that was one of my first slides. These patients are, many of them, they are multimorbidity patients requiring multidisciplinary collaboration, and this is done in a CHIP clinic. Multidisciplinary collaboration, specialized treatment, platforms for risk stratification, guidance, and therapeutic decision-making. And this should be established at any MPN center worldwide. The significant impact of this for the patients, efficient and effective patient care, better prevention and treatment, and this may also open the horizon for vaccination programs in the future, which I have not addressed in this talk. Benefits for society, fewer hospitalizations and less need for rehabilitation due to major thrombosis, reduced risk for infections and second cancer, reduced healthcare costs, and socioeconomic benefits such as better attachment to employment and the labor market. And here is just a program that we will follow when we have started a CHIP clinic at our department, and we follow this, that those without cytosis, they are followed once yearly or every 6 months, for instance, with JAK2 allele analysis. And when they then have an increase in one cell count, they are referred to our department of hematology and have a bone marrow biopsy. And what we there see is that the hematopathologist will give the answer. This is not classic MPN, but for sure we can see abnormal megakaryocyte morphology. We can see the earliest changes of an MPN disease. So when we do this, we also hope to change the WHO classification, including the CHIP patients who actually then have an early rise in one leukocyte count and then entering a department of hematology. And then we will catch all those patients with undiagnosed MPNs in the background population. These CHIP clinics will also be knowledge hubs to study CHIP to MPN transition, will be able to unravel the personalized blueprint for chronic inflammation in health to disease transition. The common goal is to reduce disease burden by exploring mutation in blood cells as the common link between chronic inflammation, vascular diseases, and cancer. I believe that the future looks bright also for the elderly. Peter, 83 years old, for 10 years, JAK2 ET, at the time of diagnosis, severe pulmonary embolism, from the time of diagnosis, treated with Pegasus, rowing approximately 75 kilometers per week, or bicycling. Also, Peter bungee jump, Queenstown, New Zealand, March 2023. The dream of the new horizon, minimal residual disease and cure. It all started with my lovely patient, Pia, and she has opened the horizon, a future that looks bright for our lovely patients. I would like to acknowledge several people in Denmark and abroad for a fantastic collaboration during the years. All my PhD students and postdocs, thank you very much for your attention. I would be happy to receive questions, and I look forward to a lively discussion. Thank you.
Thank you, sir. Lovely talk. Great insight in a very different subject. I don't think you can listen to us, so.
I can listen. Now I can listen.
Oh, wow. So then there are questions in the chat box because I asked them to put them there. But then those of you who are here, you can directly ask him the questions. Just raise your hand, put up the raise hand sign, open your videos, and go ahead with the questions. Meanwhile, maybe Dr. Girish Kamath has put a question in the chat box. We have two interferons in market, interferon alpha 2A and 2B, whether both of them can be used.
Yeah, for sure, both of them can be used. We have no studies comparing Pegasus versus Ropic, but and they have Ropic, as you know, it is given every 14 day and even once monthly, and that is the advantage of Ropic. Pegasus, many patients, when they have been treated for years, can reduce the doses to every second week.
Right. Dr. Amit, your question.
Thank you, sir, for that wonderful talk. I have two questions. Sir, what is the cutoff level for serum transaminases as well as serum bilirubin at which you will stop interferon in case of myeloproliferative neoplasms?
A very important question. And I often see patients, even being treated for several years, that they suddenly develop a rise in liver enzymes, modest, from 45 in aspartate transaminase to 100, for instance, and then I discontinue, I pause interferon, and then after 1 or 2 months, I start it again. And sometimes I see that they then tolerate it. In other cases, they do not tolerate it. And then, of course, we have a problem, and then we have to discontinue it. But I also have patients with slightly elevated liver enzymes where I just continue it. A very interesting, if we have the time to address it, is actually, you know, that Wegovy for overweight is now used worldwide for overweight. And I have some patients that actually overweight patients on interferon alpha that had increases in liver enzymes, but after being put on Wegovy, not by myself, but by others, they actually tolerate it. So I have actually put forward the hypothesis for myself, at least, that this may be due to remission of fatty liver, simply. I do not know if it's right, but it has surprised me.
Thank you, sir. And another question is, any subtype of patients of polycythemia, essential thrombocytosis, or even myelofibrosis, whatever, will you not avoid interferons? You will
No,
not
I start interferon in all patients that are able to understand my information, that I believe are able to be treated with interferon, irrespective of age. I do not, except for patients with advanced myelofibrosis, I never expose a patient with severe collagenation of the bone marrow and huge spleen and pancytopenia. These patients do not tolerate interferon. They will have severe side effects. My first paper on interferon was published in Lancet as a letter in 1980s. I treated 10 patients with advanced myelofibrosis, 0 responses, but a huge fire with inflammation mediated side effects. So in the advanced phase of myelofibrosis, you should not use it. But you can for sure use it in the patient with hyperproliferative myelofibrosis. Richard Silver, my good colleague, Richard Silver from my colleagues and co-workers, and also the French group, Kiliakian and co-workers, have convincingly shown that it is possible to treat with interferon in hyperproliferative myelofibrosis, and of course also in prefibrotic myelofibrosis.
Thank you, sir.
I have a related question. So if you have an active autoimmune disease, then you will avoid interferon?
Also a very, very, very relevant question. If you have, I can see if the patient, I have never had a patient with systemic lupus, but if it should come to that, I will be very hesitating for the simple reason that systemic lupus is a hyperinterferon state, so it will not go. I firmly believe that. But I will take another example, a good example, I think. That is the patient coming to you with, for instance, MPN and myxedema. If the myxedema is substituted, of course it is, then I would not hesitate to use it. And about 1 to 2%, perhaps a little higher, will develop either elevated or lowering of the thyroid function during interferon treatment. And then you have to balance what will be the best in this patient. But I have several patients in whom I have substituted, and they do very well.
And also, do you find difficulty in differentiating the fatigue of MPN from fatigue of interferon therapy?
In my opinion, it is impossible. So actually, you have to be very, very detailed in your discussion with your patient, because you know, some of us are actually interferon supporters, but we also know that some colleagues are not supporters of interferon, and some of them, they have in their minds the old stories that actually this was the case years ago, the old stories from the CML era, where you used much higher doses of interferon. But you have to take care, because remember what I told you, that we started the DALIA trial with low dose interferon, Pegasus 45 micrograms once weekly. That is really low. And even that low, we have a dropout rate of 20, 30, even 40% after 5 years. And most of them, but not all, but the large majority on pegylated interferon 2B PEG intron, the old introna that we used thrice weekly, there was a dropout rate of 50 to 60%.
Right. Upendra, your question.
Thanks, Dr. Hans, for that wonderful talk. So,
Thank you.
you showed us the role of inflammation in various MPN disorders. In your talk, you discussed about the role of interferon in early polycythemia vera patients, giving interferon early in the cases of polycythemia vera patients. So, do you recommend giving interferon in low-risk polycythemia vera patients, wherein we usually treat those patients with aspirin and phlebotomy only?
Yeah, for sure, I will recommend this. And if you ask this question 3 years ago, you could be provocative, saying, "Hans, where do you know this from?" And I would answer you, I know it from 20 years clinical experience with that doing so. But now, Babu and co-workers have actually shown in Lancet Hematology and in New England Journal Evidence that where they have randomized patients, PV patients, to conventional treatment with phlebotomy plus aspirin versus OPEC interferon, 100 microgram fixed dose. And actually that study had to be discontinued prematurely due to an overwhelming efficacy of the ROPIC arm. So now we have the evidence yet that you should use interferon also in the low-risk PV patient. I hope that this would answer your question.
Okay, sir, one next question. So, do you recommend giving pegylated interferon in pregnancy with myelofibrosis?
Yes. I recommend, did you say if I would recommend
Whether pegylated form of interferon is recommended in pregnancy?
Yeah, you can use Pegasus for sure, but if you ask me, Martin Grisheimer has done a lot of reviews on this and a lot of work on pregnancy and interferon alpha. Martin Grisheimer from Germany, and but if you ask the same question, if you can use Uropic, actually it is there are not enough studies on that. But you can use Pegasus. And I'm convinced that you can use OPEC interferon as well.
But sir, literature says giving conventional interferon can be used in pregnancy, but pegylated form of interferon, because pegylation should be avoided in pregnancy.
I didn't catch your question.
He says that only conventional interferon can be used and
exactly.
not pegylated form.
Yeah, we use routinely pegylated interferon alpha 2A Pegasus in pregnancy, and it is safe and efficacious.
Okay.
And also during lactation, no problem.
No problem.
Dinesh, your question.
Thank you, sir, for very informative talk. My question is there a difference in response to somebody with a JAK2 mutation or CALR mutation? And if there is a difference, what is the reason?
Actually, there is a difference. Patients with CALR mutated ET, for instance, and I treat several of them with Pegasus. And when I say this, that is Pegasus, because we have not yet access to using OPEC interferon in Denmark. So we have only Pegasus. And what I see, first of all, I see several patients in whom elevated platelet counts are normalized. In the large majority, the elevated platelet counts are normalized, or But the CALR mutation, which very often at diagnosis is, for instance, about 40 or something like that, it does not, in the same manner as the JAK2 mutation, decreases. And the reasons for this, we have tried to do some studies on it, but actually, and this is only my speculation, that the CALR mutation is also an inflammatory mutation. It gives rise to potent IL-6 production. But then on the other side, you can say that JAK2 is also a very potent inflammatory mutation because it generates reactive oxygen species. But I think that a lot of studies have to be done to explore why there is less responsiveness in CALR mutated patients. But for sure, you should not take the conclusion that the CALR mutated ET patients should not be treated with Pegasus, for instance. I would warmly recommend this.
Thank you. Thank you, Dinesh. Dr. Aishwarya?
Thank you, sir, for the wonderful talk. I wanted to discuss one case. I have one 68-year female diagnosed 20 years ago with polycythemia vera. They don't have the documents, but it was like JAK2 positive. There's one written documentation by the hematologist. And all these years, she's been on hydroxyurea. The dose was titrated as per her blood counts. So she was doing well till 3-4 years back when she started developing intolerance to hydroxyurea, because she ended up with anemia requiring transfusions. And when we came down on the dose of hydroxyurea, so the WBC platelets, they went out of control. So repeat marrow is showing maybe she's progressed to the cellular phase of myelofibrosis. So she was initiated on ruxolitinib, but due to monetary issues, again, a minimal dose of 5 mg BD only she could afford. So my thought was like, can we like switch to interferon right at this stage, or like how should we manage this case right now?
What you describe here, if I understand you correctly, you describe a PV patient having transformed to post-PV myelofibrosis. She is in the hypercellular phase. She does not tolerate hydroxyurea, and now she's been put on ruxolitinib monotherapy, right?
Yes.
And but still, there are problems with elevated cell counts.
Yes, sir.
Actually, exactly this patient is included in our papers on Combi, Pegasus plus ruxolitinib. I would warmly recommend you to try to treat her with Pegasus for only 45 micrograms once weekly, not more, and Jakavi, ruxolitinib, and then start with 10 milligram twice daily, only 10 milligram. And then you monitor her with blood cell counts every 2 weeks for 2 months, and look into how she behaves. Then you can actually, if you are lucky, and I really think that I hope that you will be lucky, then you will see what we have seen. Please read our papers in Cancer Medicine and Hematologica, that she will decrease in cell counts. It may be that she will be transfusion dependent, but if that might happen, then you can decrease the Jakavi to 5 milligrams twice daily, or even Pegasus 45 micrograms every second week. It is so important that you take your time to balance the dosages and tell your lovely patient that now we go on a journey together, and first after half a year we will have the conclusion if this is the combination therapy. Do not discontinue after only 1 month or 2 months. You have to have time span to monitor, okay?
Okay, sir. Thank you, sir.
Thank you, Dr. Jyoti.
Very nice talk, sir. My question is, sir, that occasionally in ET and myelofibrosis, we get triple negative MPNs where the driver mutations are not there and some other clonal marker is present. Under such cases, do you start them with interferon? And if you do, how do you monitor such cases?
Yeah, just to repeat, you asked, how do I monitor triple negative
Yes, sir.
MPNs, and do I expose them for interferon?
Yes,
My
sir.
answer is that I expose them for interferon. But of course, I have not any mutation to monitor, but I then monitor on simple cell counts.
Okay. Thank you, sir.
Yeah.
Dr. Saroj.
Good evening, sir. Sir, my question is that I have a patient of myelofibrosis who had portal venous thrombosis, which led to portal hypertension and variceal bleed. And he is having a platelet count around 50,000. So how should we go with anticoagulation in such a patient? And how we should manage this patient in terms of MPN?
How do you manage what is the
Anticoagulation for this patient if he had.
Yeah.
So a patient with
He also had variceal bleed.
she has a patient with portal vein thrombosis.
Yes.
Hypersplenism causing significant thrombocytopenia. So how
significant thrombocytopenia.
Platelet count is only 50,000 because of the enlarged spleen. So how to give anticoagulation in the presence of low platelet count?
This is really a tricky situation. If you and you have tried, I imagine that the patient has a huge spleen.
Yes, sir. Patient has huge spleen and varices due to which he bled, basically.
And you have tried to reduce the spleen size by Jakavi?
Yes, sir. I tried, but due to thrombocytopenia, I was not able to continue it.
Because of bleeding?
Yes, sir. Yeah.
And what have you used as anticoagulation?
Sir, I have not used in this patient because of bleeding episodes. It was repeated basically. So that's why I was asking. So
Yeah.
should we avoid or we should have been given in such a case basically?
Actually, if you have a patient that it's really a tricky case story, because if the patient is intermittently bleeding from the varices and you have such severe thrombocytopenia, this is a contraindication for using anticoagulation, in my opinion. The patient will bleed even more. But on the other hand, you have to take care of the varices. So I imagine that you have sent in the patient to a gastroenterologist for banding, etc. Right?
Yes, sir.
Yeah.
Banding was done and anticoagulation was not given from my side. So I was thinking, should I have been giving or I have did right? So that's why
I think that the varices have been banded by the gastroenterologist.
Yes, sir. Yes, sir. It was banded.
Yeah. Gastro has seen and he has done the treatment of varices.
Yeah.
Okay, sir.
I would really, of course you could try to start anticoagulation, but it will, the risk will be big for a recurrence of bleeding. But it may be an issue actually that you have to do it.
Thank you.
Okay, thank you.
Dr. Aishwarya, you have another question?
Yes, sir. Sir, I often come across some young males in their 30s, 40s who present with polycythemia, all secondary causes ruled out. the MPN panel is negative, bone marrow is bang normal. For some, I could even get the clinical exome done. Even that comes out to be normal. So such cases, like, do we counsel them only with, okay, sit with phlebotomies or hydroxyurea or like interferon? Like, to what extent can we go in such patients to get their hemoglobin in the desired range?
So just to summarize, you have a PV patient.
I couldn't label them as PV because they weren't meeting the criteria, because bone marrow was normal, the MPN panel, all the arm mutations, they were negative. Yeah.
So you have
Only,
you have no driver mutation at all.
yes, sir.
You have no JAK2, no CALR, no MPL either. And
But
you have
HB of 18, 19, 20, 21, no secondary causes.
An exon 12 mutation either.
Yes, sir.
Yeah, also negative.
And 3-4 patients I've come across such patients.
And a normal bone marrow, but elevated hematocrit.
Yes.
Erythropoietin.
Actually,
erythropoietin is like not low, but on maybe on the lower side, 8, 9, 10, 12, something like that.
Yeah, but actually the patient does not qualify the criteria for an MPN. That is my answer. If you have a normal bone marrow, of course you can repeat it, because in some patients the lesions in the bone marrow are patchy, so that I have seen rare patients where the bone marrow biopsy turned out to be normal, and then I requested a new one because I certainly believe that the patient might have MPN, and the next bone marrow biopsy then showed features of MPN.
So we continue them on
and you have also done an echo, and the patient has not pulmonary disease.
Yes, so all secondary causes ruled out.
Yes, of course.
And suppose we get a newly diagnosed PV and we are planning them for interferon. So what duration should we counsel them at because usually MPNs, we tell them lifelong. So what duration should we counsel them?
Yeah, but if you have a patient, as you describe here, with a normal, or do I misunderstand you, with a normal bone marrow biopsy?
No, sir. Now this is the second question. Diagnosed polycythemia, and I plan to put them on interferon. So what duration should I counsel them? Like, is there, or again, like usually hydroxyurea and all, we tell them it's as long as the disease progress, or whatever you call it.
No. I will intervene as early as possible with interferon alpha.
And so will you give a drug holiday sometime if the patient has beautifully responded?
Yeah, you can, but for sure, it's a good question first of all, and a good discussion. Please remember the slide where I showed you the French study, and also in our own experience. If you discontinue interferon after 1 year, and if the VAF is still 20 or 30, then you will have an early relapse. But if the patient wants this and only being treated for 1 year, and then the patient wants to discontinue, and then you can have the patient off therapy for 6 months, and then you can reinstall interferon. I think that the decision to start treatment should be a decision between your patient and of course your expertise. But if this is the patient's wish, for sure you can. But if you adhere to what we know in the literature, and we know that if you discontinue interferon, you have to have the JAK2 allele burden, for instance, below 10. That is the French study. in our experience, it should be below 5%, and then you can discontinue for 1, 2, even 3 years, where you have blood samples every 3 to 6 months, including JAK2 allele burden. And when you then can see that the JAK2 allele burden increases, or the cell counts increases within the normal range, actually, I often restart interferon. And to have evidence for all this, really hard evidence that this is right, we will set up a stop study in our department where we simply stop interferon in all interferon-treated patients above 5 years. We stop interferon to have new knowledge on those. Why can a patient still be low JAK2 allele burden and normal cell counts after 3 years versus the patient that after half a year increases in cell counts? What are the differences? We do not know. And we will have this knowledge by such a study. But for sure, you can do what your patient wishes, and you will do the right thing. Just follow them.
So one last question. Should we put all our patients irrespective of their age on statins like these polycythemias?
Is your question that should we put all our PV patients on interferon? Is
On
that
On
your
statins. Statins.
Yeah. Oh, okay. Now, okay. The statin story. Yes. First of all, of course I have to be. I have to give the answer that we need the randomized study. Okay, but we will never have the randomized study. We have tried this twice, actually. 7 years ago, we tried to set up a randomized study, but we couldn't for reasons that I have told you about. Too many patients are on a statin. But what I can tell you is that actually, I hope that the first patient will be enrolled within the next 1 or 2 months. We have the knowledge that using a statin in the background population protects against MPN development. With that knowledge, I firmly adhere to the concept that a statin will do the MPN patient well. And therefore, we also soon actually submit a paper showing that those interferon-treated patients in our outpatient clinic, being on a statin as well, they do much better than those that are not on a statin. And what is much better? That is a more rapid decline in cell counts, a more rapid decline in JAK2 allele burden, and actually we have, of course, we lack the hard endpoints if they have a decrease in thrombosis risk. But even these observations certainly have supported our next study, which will be launched with the first enrollment of a patient within 1 or 2 months. And I think that you should set a study in your outpatient as well, because it is very easy. We add in all our patients, also hydroxyurea-treated patients, we add atorvastatin 80 milligram. I know that it is a large dose, but we do so in a protocol. And I would love to send it to you so that you could set up a similar study, because the more studies that we have worldwide, the better evidence we will have to use a statin just as a normal thing as adding aspirin.
Thank you, sir.
So I am really a statin supporter in addition to interferon supporter.
Does the same apply to colchicine?
I would love to set up a study on colchicine for several reasons. It is inexpensive. It has been known for thousands of years, nearly, and it very potently targets the inflammasome. We know that colchicine used in patients with cardiovascular disease and acute myocardial infarction reduces the risk of the next myocardial infarction. This has been published in New England Journal of Medicine. Colchicine has so many lovely effects that totally that totally fits into the concept of being used in MPNs. It dampens in vivo leukocyte platelet endothelial cell activation. It dampens inflammation, etc. So it may actually be equivalent to using Jakavi. I don't know, but I would love to set up such a study.
Thank you. The 80 mg of statin is atorvastatin?
Atorvastatin, A-T-O-R.
Right.
Yeah, or atorvastatin.
Right.
But actually, we do not know. You can in 2006, I wrote 2 reviews on the use of statins and MPNs. And still 20 years should go before we set up the study. So,
right. Okay. I have one comment about Dr. Aishwarya's that case where JAK2 was not detectable and bone marrow was healthy. One, we only do JAK2 qualitative. So I would like to have your remark on patients who are negative by qualitative test. But if we look into the quantitative, there may be a low disease burden of JAK2 positivity. And second, we do not have dedicated hematopathologist available all over. So the statement that you said that some changes of my early MPN, my polycythemia vera in the marrow could be easily missed. And when they become little more overt over a year or two, then they become very obvious to a routine community hematopathologist.
Yeah.
That is a very common observation.
Yeah.
Will you recommend quantitative JAK2 for such patients?
Yeah, I would certainly. For the simple reason, and now I do not know which technique you use, but if you, you know, there are some methods that not measure JAK2 below 1 or 2%.
Yes.
And I do not know if that is your methodology, but actually the very sensitive qPCR measures to 0.5, for instance, or even lower, and digital droplet PCR measures even lower. The important thing is that, because you can ask me, Hans, what does it mean? What does it mean to have a JAK2 of 0.8% or 1%? And what we know about this is that if you have a JAK2 at 1% or above, and as a cheap JAK2, then if you do a bone marrow biopsy on these patients, and we have published this in Leukemia as a letter, about 20% will have these very, very discrete bone marrow abnormalities in the megakaryocytes. If you are a routine hematopathologist, and I totally agree with you, Agarwal, that if you are not, they may be easily overlooked, and so it is. There's no strange in this. Even if you have 10 hematopathologists sitting around the same table, they will disagree.
Sure.
Yeah. So it is really difficult.
Yeah. Dr. Akshay, your question.
So thank you for the wonderful morning, sir. So we have learned a new thing that in PV now we need to start interferon upfront. So second, my question is, if we have any somatic mutations like TP53, apart from the driver mutations, sir, will it influence the response to interferon?
As all the other questions, a key question. Some studies say that the effect is inferior, but P53, as you know, is a grim mutation, and it really warrants that something is that the horizon is dark. So I will not say that you should not do it. Simply because I think that there are, as far as I remember, there are some studies showing that interferon may stabilize even that mutation in a way that it does not evolves. But I think that I have read it in a paper years ago. But my answer is that I will try it. I will certainly try it because if you can normalize the cell counts, and the best might be that this mutation might actually decrease, that would be lovely.
And so what would be the
And
minimum
actually, when I give you this answer, which certainly is not a clear answer, I know that. It is simply because you can also read that the T2 mutation induces resistance to interferon. But I can tell you that in Silver's large cohort of PV, Silver from Weill College, Richard Silver, the pioneer in interferon research, in his large cohort, there was a patient with a T2 mutation. And that patient has been treated very well with interferon for 25 years. Just to tell the story that we should not always close doors because we have a mutation and we have literature saying so and so. Try it and see what happens.
So any minimum duration to say that interferon is working or not?
Pardon?
So any minimum duration of months for the interferon therapy when we can say that it is not working?
No. Remember my horse, that it is hard work and it is a long, tough pull over years. If you have a patient that does not lower the cell counts on 45 microgram once a weekly, then and do not increase the dose after 1 month. Then try the next 1 or 2 months, and then every third month you increase, and then you increase, for instance, to 90 microgram once weekly. Okay, and then you again have at least 3 months on that dosage, and to tell you, it is so rare. I think that I have two or three patients needing 135 micrograms, and I have treated hundreds of patients. The large majority respond on Pegasus 45 micrograms or 90 micrograms once weekly. The large majority, 90 to 95%. But be tolerant, and also be tolerant in regard to, now we have talked about what is fatigue, okay? And the non-interferon supporter colleague who is obliged to include patients because there's a protocol, he or she may say to the patient, have you fatigue? Yes, I have, but we are all fatigued sometimes. And therefore it is very easy if you are not interferon supporter, to discontinue interferon, telling that it is that is due to interferon, but actually it was because the patient is in a divorce or something or other dark situation.
Thank you, sir.
Thank you, Akshay. So can we take some questions from the chat box? Do you have time?
Yes, for sure.
Okay. So one question is related to the age and body weight, but with respect to the dose of interferon. Do you change the dose based on the age of the patient or the weight of the patient?
My answer is I do not. And then you can ask me, Hans, is this good or bad? And what I can tell you is that, of course, so many years after introduction of interferon, 30 years after interferon was introduced in the MPN, on the MPN scene, we have not done a study where we have administered interferon according to actually to body mass. But this should be done one day. But I don't do it. Of course, in the very thin patient, 50 kilos, I always start with 45 microgram. But it is not my experience that either you tolerate interferon. Of course, many patients, they have flu-like symptoms after the first 3 to 5 injections. And you avoid this by saying to the patient, you have to take a paracetamol, 1 gram, half an hour before you take the Pegasus in the evening, before you sleep, because then they sleep off the side effects. And the next day, paracetamol 1 gram thrice daily, and day 2 or 3 as well, during the first 3 to 5 injections. If the patient then still have flu-like symptoms, I is a little reluctant and try to reduce the dose to every second week for 1 or 2 or 3 months. And if it then still not works, then I have to take the conclusion and the decision together with my patient that he or she does not tolerate interferon. But it is, I have to address a very important point, and that is, and some of you will also remember what I now tell from the CML era, that those patients with CML having severe side effects on interferon, they had a much better response in terms of decline in BCR-ABL transcripts than those having no side effects. And it is my belief that you can actually say the same in patients with MPNs. And we saw this in our patients on the 50 patients being intolerant to interferon. Some of them, they have also psoriasis, they have had other autoimmune diseases. And when we then added ruxolitinib to interferon, their autoimmune disease disappeared. So that is an important message as well.
Thank you, sir. Another question is regarding pediatric MPN. Is there any experience of interferon?
Please repeat your question.
In pediatric myeloproliferative
Yes.
neoplasms.
Yeah. There is experience, and I have a colleague from Jutland with 2 patients, female, a young girl, 10 years old, where she had debut with a sinus thrombosis. And she is doing perfectly well now on the 10 years on interferon alpha-2. So, and there are papers showing that you can use interferon alpha in pediatric patients as well.
Right. Okay. If there is a question of a patient of splanchnic vein thrombosis with JAK positivity and no evidence of myeloproliferative neoplasm, will you use interferon?
First of all, it is important to say that if you have a patient with splanchnic venous thrombosis and normal cell counts, if you do a red cell mass, and I know that it is so difficult to do a red cell mass estimation, but if it is done, many of them will have an expanded red cell mass. When saying this, it is simply because the plasma volume is expanded in these patients, so you have a hemodilution. I would for sure, I would start interferon, and the biomarker that I would follow as an efficacy of the effect of interferon is the DEC2 allele burden.
Right.
Because when I say this, it is simply because two things. The large majority of this subset of patients, they will have masked polycythemia vera, so to speak. They will have an expanded red cell mass. I can refer to Jerry Spivak from Baltimore. So actually, I speak his tongue when saying this. And the next thing is that what has elicited the venous thrombosis, that is the central elevated hematocrit and the DEC2 mutation.
Other question.
So actually, you could also consider, even though the hematocrit may be in the mid of the normal range, to do a phlebotomy, because the red cell mass in 90% or 80% of the patients will be increased.
Right. Similar question is about your stroke study. There are two questions. Arterial stroke or venous stroke? And second, what was the VAF level of the JAK2 positivity in your 11% of patients? And three, whether those patients were also treated with interferon?
Very good question. It was ischemic stroke patients, arterial thrombosis. That was the answer to the first question. The next question, what was the DEC2 allele burden?
VAF levels.
Yeah, the VAF fraction. And the DEC2 allele burden, it averaged, there were both patients having below 1%, and then some were in the range of 1 to 5%, but still as CHIP. But when it was about 5 to 10%, most of them also have elevated cell counts, and they are now in my outpatient clinic being treated with interferon alpha, having obtained normal cell counts and a decline in DEC2 allele burden. And the remaining, those having DEC2 without elevated cell counts, they are followed in our CHIP clinic with cell counts once yearly.
Right. There's a question related to incidence of AML developing in patient of polycythemia vera. Is it gender specific? Do females get more of acute myeloid leukemia with polycythemia vera?
Actually, I have not read about this, but I have to update myself on that question, so to speak.
So that means it is not there. I think that covers rest everything you have already covered in your talk. So there's no other question in the chat box. Friends present over here, you have any more questions for sir? If no, then Dr. Hans, thank you very much. You're almost 3 hours, and of course the background work you have done for us, and you have educated us so much. I'm sure that interferon therapy will now percolate down in the mind of hematologists in India and all other listeners. We have listeners from about 30 countries today who have listened to you, and their vision and their attitude and their approach to patients of MPN with respect to interferon will be different from today. Extremely grateful to you. I remember you coming to Mumbai and giving us a couple of lectures about a decade ago, and we enjoyed that. And this was a real update on that with so much of data published by you and now others as well. And we have Mr. Sumit Kumar for the official vote of thanks.
Thank you, Dr. Hans Karl Hesselbell, for sparing your valuable time. It was an exceptional presentation and a highly interactive discussion that we had post your presentation. Your insights and expertise made a significant impact today, and we are really grateful for the same. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Girish Balikai, for all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you so much, everybody, and have a wonderful Sunday.
Thank you so much for giving me the opportunity to be with you, and I have really appreciated all your questions and the very lively discussion. Thanks so much, and good luck in the future. I would love to see you next time.
Your
Bye-bye.
perseverance of work
Bye-bye.
on interferon, your
Bye-bye.
perseverance of work on interferon has to be appreciated, and you are virtually father of interferon therapy in MPN.
Thanks so much. Bye-bye.
Bye.
Lovely Sunday.
Lovely, sir.